Yeah. Close first. That's what we do. Hmm? May na how many participants are eight? Just four, correct? Yes.
After Sanskrit,
That's all. But
how about the other?
they can give it to me since we have this.
Can,
I just checking.
can the others give a thumbs up if they can hear me clearly? Something like this. Okay. Good afternoon. So we'll have two lectures for this afternoon. We'll have partner case and the seats in front. People at the back, please go forward. It's hard for me to project and the light's not good. People at the back, go in front. You don't want fun. Objectives for this afternoon will be to review anatomy of the nerve. Saan intended for that? Ganyan. Tapos, minsan mo yan, ito lang. Tapos may ko, pipindan mo, pipindan na agad. Nakikintay mo yan? Pagka hindi ka, you know, so that's your anatomy. Good cards, so regular anatomy, upper inversion anatomy, then we will give that way back to the so, forward absolutely available. Upper, outer, quadrant. Okay. Upper, outer, quadrant, so, if you're doing the basic exam, that's it. You not examine all the quadrants, or all five quadrants. But if you're going to look for things where they will be moving, get forward or outer. Why? Because the water more gradually improve. Start. And cover so that starting with posture, blocking, and the posture for each one. Then by posture is here. How do you investigate? Of course, it's like this one, but you can do middle or you can do purpose. Step. Trying to do starts or balloons. But you can then gauge. Most of start breastfeeding because it's so small. But you have to encourage them so that it will relieve them flowers. So when you breastfeed, or not use so many to breast milk. So first it would be applying the relievers to relieve the pain. And if the it has it, sorry, you can do aspiration damage. When any doctor responds. It's important because it is represents movements in either market. It's the very short consulting of the that. So what's the characteristic of people with that increase and very control and students are women, rapid age, etc. These are not common issues. Women arriving. Is it basically? Then you major the symptom acknowledgement for this one. Okay, so since it's not infection, you do not need an abscess. You have to do excision to remove the damage. So those are the difference. Because you know that pathophysiology of the origin of the different study. Another with the necrosis. It's uncommon and usually these patients present with a single trauma. Previous surgery or previous radiation therapy. So what happens during sensor focus on necrotic vaccine with different building at 5 millimeters. So there's chronic inflammation leading to cysts. This is commonly confused with carcinoma due to fibrosis because there's disordered mass and there's calcification seen on the mouth. So be careful, especially if it's benign. For sure, potential.
Can we visit the waiting room now? It's just getting disconnected. Yeah,
What will I do? Wait, this one?
I need just move the waiting room.
Yeah, I agree.
Because in between due to the network, it is getting disconnected. So this gets on in my
How?
waiting room. So we will everything video.
Here, not here.
Yes, yeah. Perfect. So there we have 30 minutes.
We want to share the YouTube also.
I want to get a few.
Oh, she started. But why didn't
Alright. So another would be your non-proliferative fibrocystic change. Yes. And then the whole restrictions. If you see most common, nowadays you have to know most common breast disorder that's not proliferative fibrocystic change. It's also known as fibroadenosis. So there's no associated risk of progression of cancer, and usually these develop in women 20 to 40 years, no symptoms. So it will just present as a lump, may present as a nipple discharge for calcification. So it's just a cystic change, apocrine metaplasia, adenosis, and fibrosis. Can be further classified into two types. It could be fibrosis or it could be cystic. Of course, fibrosis, it will be fibrous, similar to scar tissue. So it will be one solid, more, one firm, one. Of course, if it's cystic, it may be softer, it may be fluid filled, but may get bigger at any point in time. Okay. So how do you evaluate? You do mammography. So mammography is recommended for women for more than 40 years of age. Of course, central will be ultrasound. And of course, breast biopsy. Okay. So most will not need treatment, close follow-up may be advanced. Okay, if there's fluid, you remove the fluid. If the mass is big, you may remove. Okay. Pain will be addressed by pain relievers. Okay. And the like. Next would be proliferative disease without atypia. So without epithelial, this is also called epithelial hyperplasia. So there's simply an increased number of layers of cells lining ducts and acini. So the involved ducts and acini are filled with overlapping proliferating cells. Without atypia, sclerosing adenosis. So sclerosing adenosis would be characterized by increased number of acini and stromal fibrosis within lobules. Can be associated with calcifications which may be detected on mammography. So then we have a typical hyperplasia. So this is epithelial hyperplasia with a typical architectural and cytologic features. These can affect ducts. So it can either be a typical ductal hyperplasia or a typical lobular hyperplasia. It could resemble carcinoma in situ, but cannot be distinguished yet with clinical radiologic features. Of course, with the increased incidence of screening through mammography and ultrasound, the detection of breast masses with this diagnosis becomes more prevalent. Okay, so those are benign changes. These are benign tumors. So if your fibroadenosis is your most common breast disorder, fibroadenoma is your most common benign tumor. Okay. It's a circumscribed lesion composed of proliferating glandular and stromal glands. So usually presents in young women less than 30 years, presenting with a lump. Okay. It could occur in giant forms, but usually 20% complex fibroadenoma. Okay. So these are the types. Pericanalicular, more fibrosis. Intracanalicular, meaning less fibrosis. And giant fibroadenoma. Okay. So giant fibroadenomas are uncommon variants of your fibroadenoma. Of course, it's characterized by rapid growth. So it happens in late adolescence more often. Size usually grows more than 5 centimeters. Is usually encapsulated and more often benign. Okay. Underlying mass can cause a major distortion of the breast. Okay. Of course, if it happens in adolescent women and you're causing a disfigurement like this, of course, this would be cause for concern. That would bring your adolescent to your clinic. So investigate with a mammogram. Okay. But will not always require excision unless your cytology is suspicious, it's very large, or the patient wants to remove it. Okay. If it's needed, you can proceed with a lumpectomy, you can do bryo, or you can do suctioning through ultrasound. Okay. Those are your managements. Okay, lumpectomy, you remove, and that's the most common use method that you will learn in surgery. Cryo, a small needle is placed at the tumor center, and then a tip of the needle is used, and you do freezing. Okay. and the drainage. Okay. Another benign tumor is the papilloma. Okay. Benign papillary epithelial tumor, which occurs mainly in large ducts. So there's papilla increased but fibrovascular stalks lined by layers of proliferating epithelial and myoepithelial cells. Most patients present with a serous or bloody nipple discharge. So if you see serous bloody nipple discharge, think duct papilloma, unless otherwise correct. Another benign tumor would be Phyllodes tumor. So this would be, as the name implies, your leaf-like cystosarcoma phylloides or Brody's tumor. Okay. Not like the name, it's not a sarcoma, that's cancerous, but recurs locally after simple excision. It does not metastasize, present in middle-aged females, and can only be distinguished on histology and overlying skin maple nephron. That's why it's easily confused with malignancy. Therefore, we have to know how to distinguish. Okay. So how do you differentiate? Do you differentiate with age, with tradition, with the behavior, how it looks to sound in cytology? Okay. So these are just histological slides to show. Don't worry, I will not ask for histo slides during gynae exam. Work up again, biopsy. Do a corneal biopsy to show your issue diagnosis. So there are different classification at your level. This is nice to know if it's benign, borderline, or malignant, what is tumor. So why is it important to differentiate these breast tumors? Because they would have different relative risks for invasive breast cancer to develop. So it's important that you differentiate among the previous. So among the following, no increased risk for invasive cancer would be like so. Mastitis, fat necrosis, duct ectasia, non-proliferative fibrocystic disease, and simple fibroid. No increased risk. Okay. Slightly increased risk would be your moderate or florid hyperplasia, sclerosing adenosis, complex fibroadenoma, and duct papilloma. Of course, with the name implying moderately increased risk, you have your atypical ductal or atypical lobular hyperplasia with moderately increased risk for invasive. So it's not saying you're benign, it's malignant, but there's risk because you already developed something in the breast. And that poses a risk for it to degenerate into something cancerous. This is hard. Okay. So we look at carcinoma of the breast then. Of course, we start with epidemiology, and it's the most common diagnosed cancer in women in all ethnic groups, in all age groups, 15 years and above. So incidence starts to increase at 30 peaks at 50 to 59, then starts to decline. So this is your specific cancer incidence per 100,000 population. Okay. And what causes breast cancer? Unknown. And every woman has a risk of developing breast cancer. And mind you, it's not just women who have breast cancer. Also the males can have breast cancer as well. So what are those risk factors? Of course, being female by itself, you have higher risk to develop breast cancer. Age, 40 years old, premenopausal, 50 years old, postmenopausal. Of course, any history of neoplastic disease of the breast, whether it be a prior breast cancer or a new one, in situ, your atypical hyperplasias, your benign breast disease, we will mention, would be all risk factors of malignancy. Of course, in any malignancy, any family history, especially if you have breast cancer among first degree relatives. Okay. Sister carries more risk than mother. And of course, you know your BRCA1 and BRCA2 would be your mutation that would be most at risk to develop future breast cancer. Other risk factors, previous radiation exposure, multiple exposure to radiation for various reasons. Okay, puts you at high risk of developing cancer. Okay, reproductive factors. Okay, these are hormonal exposure. First pregnancy occurred more than 30 years old. Non-neutrality, breastfeeding, oral contraceptive use, unexposed estrogen use, hormone therapy, age of menopause more than 55, age of menarche at 12 years old. What's common among these factors? This is highly related to estrogen exposure or unopposed. 30 years old got pregnant, meaning up to 30 years old, your estrogen was not interrupted by a pregnancy cycle. Nulliparity, you were never pregnant, estrogen never interrupted. Breastfeeding for duration for 12 months, breastfeeding, your estrogen is limited. Oral contraceptive, you have exogenous estrogen. Unopposed estrogen, obesity, age of menopause, early menarche, all related to estrogen exposure. Breast density, higher breast density from mammography. So risk is 2 times in scattered fibroglandular density to 4 times in an extremely dense breast. And of course, lifestyle also related to estrogen. Alcohol, also estrogen. And moderate and vigorous exercise. Okay. So what's the pathophysiology? So mutation, cancer, inactivate, cells proliferate, and the mutation multiplies, and thereby proliferates with abnormal cells. Okay. So what's important would be your classification. Carcinoma in situ could be ductal or lobular in situ, and your different forms of invasive carcinoma. Okay. So histology classification. If you will see, most of your breast cancer would be your ductal carcinoma. So most common would be your intraductal carcinoma comprising 75%. Less rare, but still more common than your lobular would be your ductal carcinoma in situ. Less would be the two, a lobular carcinoma in situ and invasive lobular carcinoma, which comprises only approximately 5% each. Okay, so what's ductal carcinoma in situ? This is 15%. So increased incidence with increased use of screening and early cancer detection. Okay, this is increasing because of mammography, and this would comprise of 50% of your screen detected cancers. Could also have palpable mass, yes, but more often than not, there's no palpable mass yet and detected by screening. Okay, this is characterized by proliferating malignant cells within ducts that do not reach the basement membrane. So it has not invaded your ducts or basement membrane. So it is classified according to patterns, whether it be a comedal, cribriform, etc., etc. It will be different rates, could be low risk, intermediate, or high risk, or the like. And is often multifocal. Men with ductal carcinoma in situ are at risk of invasive cancer, especially in the same breast. How about LCIS or lobular carcinoma in situ? So this is relatively uncommon. So this is a malignant proliferation of small, uniform epithelial cells within the lungs. This is also marked increased relative risk for invasive cancer, 8 to 10 times in either breast. Okay. As I mentioned, invasive ductal carcinoma, most common form of breast cancer, especially in the poorer populations. Because of screening, there's increased incidence of detection of cancer, especially in developing countries. Especially in developed countries. How do you present? It presents with a hard, irregular palpable data. Okay? With your thickening or dimpling of the skin. You have your Paget's disease of the nipple. This is also your ulceration or inflammation due to introductal spread to the nipple. So the dimpling would present with tendering of the skin, nipple retraction, your axillary mass, and remember this, metastasis goes to the lung, brain, and bone. You will see later in lobular ductal carcinoma, it will metastasize in different areas. Okay. As with your in situs, there are different histologic types. Most common is your serous carcinoma. This is a irregular hard mass. And histology shows infiltrating clusters of malignant cells in a dense fibrous straw. There's some special types. There's mucinous, there's capillary, and the like. Okay. Invasive is much less common than introductal, but present with similar features. But they often behave more bilateral and more multicentric than your invasive ductal carcinoma. Okay. Histology would be small uniform cells arranged as strands within a fibrous straw. This is what you call Indian file. So around uninvolved ducts, that is your bullseye pattern. Where does it metastasize? CSF, serosal surfaces, and pelvic organs. Compared to your invasive ductal carcinoma, which metastasizes where? Where's your IDC metastasizing to? If ILC is CSF serosa and pelvic organs, your intraductal metastasizes where? Three. That's just 2 slides ago. Where? I, yeah. So this is where usually it grows. Some history taking, of course, you look at the risk factors, age, you look at the location of the breast, size, when it PQRST of the mass, if it's painful or painless, hard or soft, is there discharge, is there history of radiation or malignancy, marital status, pregnancy status, menstrual history, family history. Okay, all of those risk factors will come into play as you look for risk factors for that patient. You describe the pain, you look at the lump, nipple discharge. So if you had a wish, think mastitis, breast abscess. If it's serous or greenish, think duct ectasia. If it's bloody, duct papilloma or carcinoma. If it's milky, galactosils. So these are buzzwords that should be at the back of your head always. The other symptoms, of course, that will point to malignancy would be your systemic symptoms, loss of weight, loss of appetite, bone meds, etc., etc. How do you inspect? You inspect breast, symmetry, size, shape, erythema, skin, if there's retraction, nipple, if there's discharge, ulceration of the neck. I think it's important that you look at all positions. First, arms relaxed, then hands on the hips, then arms raised, and then bended forward. Okay? So these are the positions for your breast examination. You learn that you'll learn that in surgery, or you will also do that for your Oscar in Ghana. Then you palpate. In sitting, semi-recumbent and recumbent, you look at all quadrants. But again, where do you expect the abnormality? Mhm. Right. Upper, outer quadrant. Okay, so you can either do it in circles, in wedges, or lines. Just as long as you do it systematically so as to you are not missing any part of the breast. Okay. What do you have to take note of? Temperature, tenderness, number. Most common mistake, if you already palpated one, oh, there's already a mass, then you stop. What if there's two more, three more, four more? What if there are five more on the other breast? So do a thorough breast exam for your whole quadrants. Size, shape, surface, consistency, and then don't forget sila lymph nodes. Of course, that's your lymphatic drainage. And look for signs of metastasis. Lung, brain, or bone, CSF, pelvic organs, especially skeleton, lungs, liver, skin, and brain. Okay. How do you prevent? Of course, you do screening. breast self-examination by the individual. You do clinical breast examination or you do an ultrasound or mammography or MRI. If you do see that you have risk or you already have starting lesions, you can do risk reducing surgery. Or even if you don't have yet, if your risk is high, you can do prophylactic mastectomy, like what Angelina Jolie did. See, it reduces the risk as high as 90% for women with high risk of getting breast malignancy. Also, as prophylactic salpingo-oophorectomy reduces risk of both ovarian and breast carcinoma if you are BRCA carrier. Okay? So this is a hereditary breast of carrier of ovarian and breast cancer. Of course, mammography is one screening tool so that we can detect breast cancer early. Okay. When do you consider mammography? High risk women below the age of 40 years. Okay. In patients postmenopausal hormone replacement therapy, you should do screening mammogram as well so that you have a baseline. Okay. You have your annual or biannual screening. Okay. You do screening. Okay. That's your mammography. Okay. When to do your breast exam. So you do it monthly. You look for breasts. Usually for menstruating women, same day each month. Okay. 5 to 7 days after beginning of their period and examine all breast tissue. Screening recommendations for general population. Okay, in women 50 to 74 years old, every 2 years. Okay, low risk women 40 to 49, not offered routinely. Okay, but should not be denied screening if they want to do so. For high risk, what's recommended? Age 30, both MRI and mammography. Okay. Of course, do your biopsy so that you have your tissue diagnosis. Okay. TNM staging, so T1, T2, T3, T4, that is your tumor size. And would be the number of nodes, so according to number, and metastasis if there's metastasis or not. So that is your TNM staging. Okay. So know this basic classification and this finding. So whenever you do an ultrasound, you will have findings of a virus 0 to 6. Okay. 0 means it's inadequate and you cannot conclude anything. A 1 to 3 means you're benign and you will just warrant repeat ultrasound after 6 months. 4, 5, 6 warrants at least a biopsy agent. Okay? Your expected finding or expected steps whenever you see an ultrasound result. How do you manage? This is nice to know. So, but it's important that you know how breast malignancy is managed. Of course, you have your breast conserving surgeries, those who want to preserve their breasts. Remove cancer while leaving as much normal tissue. So this is often an option for early stage cancer. Okay? You allow to keep most of the breast. So what are the contraindications? The ratio of the size is larger. and it would not result in acceptable breast. Like sometimes, like tira ka pa, or you left a breast tissue but it's very small. If your cancer is multifocal or multicentric, you cannot do lumpectomy. Or you cannot do local radiotherapy. If- So you cannot do breast conservation. Okay. Axillary surgery. You remove one or two or three level 3 nodes. Okay. Can be done. Okay. Indicators for axillary surgery are the following. Tumors just less than 3, multicentric, clinically positive nodes, breastfeeding, and the like. Okay. So this is early management of breast cancer. Okay. So this is surgical. And just know the difference between simple or total mastectomy. Simple, you remove the entire breast. An axillary lymph node dissection is not done. However, some are occasionally removed because they happen to be involved with tissue. Okay. So who will get simple mastectomy? Those who have BCIS, prophylactic mastectomy, and the like. Okay. Your modified involves the removal of both breast tissue and lymph nodes. Okay. Removes the entire breast plus the lymph node, and no muscles are removed from beneath the breast. So that is your modified radical mastectomy. So if it's invasive, you do your modified radical mastectomy. Okay. And your radical, the difference is between the surgeon also removes the chest wall muscles under the breast. Of course, if it has spread, if the malignancy has spread throughout the chest muscles, you have to do a radical mastectomy to prevent metastasis. Okay? There's partial mastectomy and nipple sparing mastectomy as well. Okay? So these are the boundaries of a mastectomy. Of course, it's important you do breast reconstruction, especially for women. This is most would be their concern, how they would be disfigured after surgery. Okay? So these are your mastectomy recommendations for delayed reconstruction. Okay? So the chemotherapy could be done before surgery or after surgery. That is to destroy any remaining cancer cells. And these would be recommendations whenever a post-mastectomy radiotherapy would be needed. Okay? I think that's it. Just follow up. Of course, after 3 years, with minimum 3 years, every 3 months for the first year, then every 6 months for 5 years, then annually thereafter. Of course, you have to do your annual mammography to look for recurrence. Okay. And shortly, you have your male breast. So that is a problem of the gynae male enlargement of the male breast due to hormonal imbalance. So some are physiologic, seen at puberty or old age, but there's also pathology associated with liver disease, testicular tumors, drugs, the like. Can be unilateral, bilateral, and present as diffuse enlargement. So it's a clinical marker of hyperestrogenism, and it's important, even if it's male, you rule out neoplasia. Although carcinoma is very rare in males, when you do have cancer in males, pathology and behavior similar to cancer seen in women, although because they have less breast tissue, they will manifest more with skin involved. Okay, so that is breast disorders for you. Let's have GTD. This is a little bit shorter. Right. Okay. When you start if the practice, this disease will be more common than our Western animals. That's why some will want to see each ball when they really go to our region so that they can see cases like this. So if I have a group of them style views typified by abnormal trophoblastic proliferation. As the name implies, it's trophoblastic disease. And its manifestation is markedly increased in HCG. What is HCG known for? What is HCG? Which are pregnancy hormone. And what does it for? Each are classifications of your GTD. So it could be molar pregnancies, clinical pregnancy. These are your H1, either complete or partial, invasive mode, or retroblastic tumors. Could be a carcinoma, placental cytoplastic tumor, or epithelial. Let's see how it's differentiated. It could also be neoplastic malignancy. So your tumors will become an invasive mode, your carcinoma, PSAT, they usually follow their age small, followed by increases in HCG, usually treated by chemotherapy. But this is how it looks like. Your identity mode is atrophoblastic proliferation and villi with stromal edema. So it's edematous and it's proliferated, meaning it's larger than what it's supposed to be. So, if you have a 6 weeks pregnancy compared to a 6 weeks age model, which you think would be larger, your age model. So, one of the signs of your age model is that it is not common age because it's inevitable. It's proliferative. It could either be complete or partial. What does complete or partial mean? It can either have a baby or an absent fetus. Why is it important to differentiate? Risk for comorbidities, risk for malignant degeneration. Okay. Complete villi with massive clear vesicles. The partial is the one that has vital tissue. And these are the differences between partial mole and complete mole, according to karyotype, according to clinical presentation, and according to age. So these tables are all found in your buildings. Okay. And then as I have mentioned, it's where in some countries and more in others. So 1.48 in 1,000 births in Saudi Arabia. In Europe and North America, 10 times higher. In America, 1 in 600. In India, 1 in 400. So it's called more common in the tropical countries. It occurs in extremes of the productive age. And of course, the risk of a prior high degree form more increases risk to as high as 20% at complete moles. Complete 0.9, partial 0.3, but when you add to complete moles, the risk jumps up to as high as the moles. Storage. You have your maternal chromosome inactivated 23X. You have your maternal chromosome duplication 46XX and will divide into 46XX and XX. What happens with your that's what happens with your complete? That's a diploid. Your partial is a triploid, that's why there are maternal and paternal chromosomes. So you have 23X and you have 23X and Y. So that will produce a 69XXY for the 69XXY first, producing your partial HMO. So HMO could also have your twin pregnancy. So one could be normal and is compared with an involved more molar pregnancy. So differentials could be at the placental mesenchymal dysplasia, subchorionic hematoma, or choriangina. So you have to distinguish, this is distinguished by your chorionic sampling, amyosynthesis, or fetal cord blood sampling coupled with karyotyping a confirmation. Okay. Complications of HMO associated with thyrotoxicosis, associated with preeclampsia, hemorrhage, preterm delivery, and eventually developing subsequent GDL. Okay. Findings are better because it's detected because of ultrasound. Okay. That's why now most identified neurons are treated before complications arise. So these are the usual clinical findings of HMO. Of course, you're pregnant. Okay. Complaining of vaginal bleeding. So it's like abortion. Okay. So it will produce your anemia. Because of your excessive HCG, you will have excessive vomiting because of your HCG levels. As I have mentioned, you have enlarged uterine size according to age and a body uterus. Okay, retained cysts are common. Increased free T4 and decreased TSH and findings of preeclampsia and eclampsia. Okay. So central in diagnosis of your beta HCG would be your serum beta HCG measurements. So this would be elevated above those expected for gestational age. And usually the levels are 100,000. Okay. So hook effect. Okay. This can lead to erroneous false negative urine pregnancy test results. What's this? Pregnant but negative. Why is that so? And um, this can be counteracted by doing a dilution test. You get 1 ml urine and you dilute it 7 times. And then you put it in the pregnancy kit. And then what was previously negative was positive. Why isn't that so? That's because your assay can only what's for. So it becomes diluted. So the assay can only recognize up to a certain level of HCG, right? But in each mole, your HCG is at extreme levels. So you have to dilute it at least 7 times so that the assay can recognize the range. Because HCG levels of each mole, you expect 100,000 level of beta HCG. Compared to what the assay can detect, the assay can detect 2 to 25 level of HCG. So that's the hook effect. Okay. Because of the advent of ultrasound, okay, the diagnosis of H1 becomes easier. So this is the classic appearance of your H4. And this is your snowstorm appearance. Okay, anechoic cystic spaces of different size and shape. But no fetus, no amniotic sac. Okay. It's vascular and there's no internal flow reflecting the vascular villi of completeness. Okay. Your placenta could have fetal or fetus tissue can be found within the gestational sac. If your fetus is there, they usually die in the first trimester because they're growth restricted, they are oligohydramnios, they have defects either in the limbs or CNS. Okay. What does it mimic? Vaginal bleeding. Think of incomplete or missed abortion. Enlarged uterus. Think of multifetal pregnancy. Enlarged abdomen. Think of diamyoma with cystic degeneration. So these are cost differentials that you have to consider in each small patients. Okay. What do you do? Post evacuation surveillance is indicated. So of course we evacuate. Of course that is to this establish molar pregnancy. Okay. Immunohistochemical staining for P57 KIP2 to make sure that it's H1. So you do genotyping to look at the source of parental alleles. Okay. Deaths are rare now because of early diagnosis. It's evaluated timely and because of surveillance for the progression of GTN and our ability to identify complications early on. So these would be your preoperative and intraoperative and post-evacuative workup. Okay? So how do you terminate? We recommend suction curettage as the preferred treatment. Okay. You dilate the cervix with a dilator and then you do curettage, like a vacuum. This is done under anesthesia, under IV access, ideally with blood products ready to transfuse in case your blood you have a lot of blood loss. Okay. So what's the difference between an ordinary dilation curettage to a suction curettage? So your cervix is mechanically dilated to allow insertion of a large cannula. So you use also oxytocin. You may use sonography to help ensure your cavity is empty. And you do a curage with a large loop, okay? And then you do suction. Okay. Post suction, you may give your to RHD negative women because fetal tissues with a partial mole may include red cells with the antigen. Okay. So routine chemotherapy is not recommended and is not improved with prophylactic chemotherapy. But we will see later who are the patients who will benefit from prophylactic chemotherapy. Okay. Other management, especially if it's of size, of completed family size, you can do your hysterectomy with ovarian preservation. Okay. For women who have finished childbearing and who carry complete moles with high risk features, you may do your hysterectomy. Leave the ovaries. Because women aged 40 to 49 years will have 50% risk to subsequently develop neoplasia. And of course, doing your hysterectomy will drastically reduce this occurrence. You do not need to remove your decolletage cyst. Okay? So you do not do your labor induction and hysterotomy for molar evacuation because this will lead to increased blood loss and what's more, raise the incidence of persistent trophoblastic disease. Okay, how do we do surveillance? We do serial beta HCG measurement to detect persistent or renewed trophoblastic proliferation. Okay. So initial HCG obtained 48 hours after evacuation, then done every 1 to 2 weeks. Okay. Median time for such resolution is 6 weeks for partial moles, 7 weeks for complete moles. Okay. Once it's undetectable, this is confirmed with monthly determinations for other 6 months. So you see how tedious post surveillance is. And after 40 hours, then every 2 weeks, then every 6 months, and so on. So of course, you have to avoid getting pregnant to avoid confusion if the rising beta HCG is due to the persistent GDN or to another pregnancy. So you have to give reliable contraception. So either a depot or an IUD. Of course, you cannot give hormones. Of course, you cannot give your uh, other methods. Okay, so these are the people at risk for GTM. With post-surveillance, you have plateauing levels of beta-HCG. Complete moles, as we have mentioned, 20% incidence of malignancy, compared to 5% only for partial moles. Older maternal age, their beta-HCG pre-evacuation is more than 100,000. Uterine size is large for gestational age. Decadutensis, more than 6 centimeters, and a slow decline in your beta-HCG levels. If it's GTM, placental site tumor is developed after pregnancy more often than HMO. Okay? They are distinct but usually diagnosed by persistently elevated serum beta-HCG levels because tissue is infrequently available for study. Okay, so this is the criteria for GTN. Plateau of beta-HCG level for measurements during a period of 3 weeks or longer. Rise of serum beta-HCG level more than 30%. 3 weekly consecutive measures or longer. Serum beta-HCG remains detectable for more than 6 months. And you satisfy the histological criteria for choriocarcinoma. Okay. You have your staging and prognosis. So it's aggressive and invades the myometrium and has the propensity to metastasize. Still, the most common finding of GTN is bleeding associated with uterine subinvolution. Okay. It can cause intraperitoneal hemorrhage and will present with persistent bleeding after any pregnancy. Think HMO or think GTN. Assess the size of the uterus, examine the uterus, look for lower genital metastasis, which are usually blue. Okay. So determine your beta HCG and your CBC picture. Then assess your liver function test, sonography, PET scan, and if there's no extrauterine disease found, quiet please. Please do a second curettage. Okay? Or you may do a hysterectomy. Okay, then you measure every 2 weeks until 3 consecutive weeks until beta HCG will be undetectable. And then you repeat every 6 months. If it's persistent, you repeat a curettage, or you already undergo staging, or you start chemotherapy. Okay. So this is your FIGO staging and diagnostic scoring system for GTN. So this is your WHO prognostic scoring system. So this is according to age, antecedent pregnancy, interval of pregnancy, and it's easily classified. If it's more than 8, then the risk would be high. Lower than 8 or less than 7, risk for GTN is low and classified according to such. So memorize this table because it could be invasive mode arising from partial or complete moles. So this would be tissue invasion by trophoblast and whole villi. So they penetrate deep into the myometrium and sometimes would involve as far as the peritoneum, the vault, the adjacent parametrium, and the like. But just metastasizes locally. Okay, another would be gestational choriocarcinoma. This is the most common trophoblastic neoplasm to follow a term, pregnancy, or a miscarriage. Okay, so cells are like an early cytotrophoblast and syncytial trophoblast containing no villi. So this invades both the myometrium and blood vessels to create hemorrhage and necrosis. Okay. Okay, another would be your placental site trophoblastic tumor. This is uncommon, which arises from an intermediate trophoblast at the placental site. Your beta HCG may not be as high as ones we usually see in choriocarcinoma. Okay, so they produce different forms of HCG. We prefer hysterectomy because these PSTT would be resistant to chemotherapy. Okay. Sometimes, for higher stages, adjuvant chemotherapy is also given. And lastly, you have your epithelial trophoblastic tumor. Rare and will develop from a chorionic type intermediate trophoblast. So this involves mainly the uterus. Okay, there's bleeding, but there's low HCG levels. Okay, as also hysterectomy is recommended because this tumor is resistant to chemotherapy, although this does not metastasize commonly. Okay, combination chemotherapy is also employed. Okay. Usually, chemotherapy will suffice. Primary treatment and primary treatment would be with methotrexate. In some GTN cases without extrauterine disease, sometimes a secondary evacuation may be needed. Okay. Okay, what are the regimens? So single agent, usually it's methotrexate or actinomycin B. But methotrexate is more commonly used because it's less toxic. Okay. If you're doing combination chemotherapy, usually what we usually use is Emaco because cure rates are reported to be at 90%. Emaco is etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. Although even if you do chemotherapy, adjuvant, surgical, and radiotherapy also can be involved. So surveillance. So of course, monitor for hemorrhage from metastatic sites. Of course, because of metastatic sites, there could be respiratory failure, sepsis, multi-organ failure due to widespread disease. Okay. Surveillance is continued for at least a year. Contraception is also critical, especially now you have teratogenic effects of your chemotherapy. Okay. Sometimes you have to be observant also. If there's no evidence of metastasis, there may be low levels of HCG levels that are plateauing. You still have to observe. Okay. Advice regarding subsequent pregnancy. Okay, because they do not have impaired fertility and their pregnancy outcomes are usually normal, but they have risk to develop triploblastic disease. So we have to recommend sonographic evaluation in early pregnancy so that you can detect age mold early. So women who had successfully completed chemo advised to delay pregnancy for at least a year because there could be relapse or your methotrexate persists and cause teratogenic effects. Okay. With prior treatment, placenta of subsequent pregnancy automatically sent for evaluation and delivery. And serum beta HCG level is measured 6 weeks postpartum. Even if the current pregnancy has been shown not to be diagnosed with HU or GDN. Okay? So it's very good measure that even if everything is normal, patient has history of HMO, you check the placenta, you check their serum beta HC level 6 weeks postpartum. Okay, we've had 2 long lectures. Thank you. That's it for today.